after passing, many of you, most of you will remain in this country and some may live in other countries. So, you have to have some amount of orientation about the patients. Now, deliberately I have taken a good amount of effort to collect the pictures from our own population as far as practicable, and all the rare diseases, whatever I find, I try to show it to you. So, that was in the last class. A good amount of time was there. I have spent it on showing those photographs, because the actual text you will get in the textbook and also in the lectures, in the video lectures are available in the YouTube, internet. But those pictures from the real OPDs are conspicuously absent. I have seen many, I have gone through many lectures in the internet. So again today, have you read ACM? How many of you have read ACM? Whatever I have told you, that was a primer to stimulate you to read ACM. Please raise your hands, how many you have read it? See, if you have not read it, then this second part I cannot continue. I have given you a buffer time of 10 days time. So if it is a one-way lecture, then there will be no implication. You will not understand anything. I want that you ask some difficult questions to me, which I will not be able to answer. And I am telling you again, you go through all the topics in details what I have taught. And if you require 1, 2, 3, 4, any number of SGD classes where you can interact with me liberally, no issue. Not even in this class, also in the first year, in future also. We want you to understand the subject matter before you really go into the clinical practice. And again, I am telling you, I have told you repeatedly, my target is not first year MBBS passing, but my target is to make you qualified for the NEET-PG and to become a good doctor. If you have not read it, then how can I say this is one, these particularly storage disorders, particularly you have seen it, say glycogen storage disorder, lysosomal storage disorder, these diseases are very, very rare. Once in a blue moon you will get it in your life. And until and unless you see something, you have got some amount of idea, particularly those who will be practicing pediatrics and obstetrics. They must identify the disease at a very early stage, because when the disease is detected at a later stage, a considerable damage has taken place. And I have told you several times that the child, it will not only be a burden for himself or herself, but to the family itself. Now see one example. This case is a classical case of Hunter syndrome. Hunter and Hurler syndrome, it is very difficult to get, but until and unless you are in a very super specialty hospital like AIMS, PGI, Chandigarh, CMC, Vellore, it is very difficult from a general hospital. But the photograph I have been showing there, that child was moving by Holdibari Express to Kolkata to get the treatment of enzyme, and during that time the video was taken, and I have taken still photographs also. So don't forget this disease, at least this remember. See, you see the child generally dribbling of saliva from the mouth. You see the appearance? Have you noted? So you have to a little bit, I had to request to get the photograph, but they will not allow it. The baby, this is a grossly abnormal baby. This is again I am showing you, just see the baby. This type of baby, wherever you will get it, try to get an idea that you try to get a photograph or get the details. And as a medical person, you will earn very huge amount of money. There is no doubt about it, but at least try to help this helpless child. They will not get treatment. The treatment of this thing is an enzyme replacement therapy. And in our early days, in around 2010-12, the cost of treatment was nearly 1 crore per year. I mean, even after spending so much of mind, good quality of life cannot be given. The enzyme is very costly. Fortunately, government of India and West Bengal is giving the baby was getting the treatment from SSKM Hospital, Kolkata, IPGMR. This is an enzyme deficiency. I am telling you, this L-iduronidase sulfatase. That enzyme is costly. This is Hunter syndrome. Remember, this is Hunter syndrome. One picture I will show it to you. Hurler syndrome. This is a classical case of mucopolysaccharidosis. Remember, mucopolysaccharidosis. This is Hunter first disease. I will show it to you. That is Hurler syndrome. This is Hurler syndrome. See, this is type 1 mucopolysaccharidosis. There is a chart in your book. You will get it. There is a chart in your book. You will get a list of diseases. Number 1 is Hurler syndrome. Remember, Hurler, it was an 18 years old child. I mean, can you imagine what is it the appearance of an 18-year-old child? And see the appearance. There is a abdomen is large, enlarged. There is a coarse facial features. And see, this is a disease of the extracellular matrix, mucopolysaccharidosis. So, if the extracellular matrix is not proper, so there will be enlargement of everywhere, all the organs. There will be organomegaly will be a giant feature, coarse features, coarse structure appearance will be there. Macroglossia, that means the tongue will be enlarged. And there will be gross abnormality. You just remember, this is a type 1 mucopolysaccharidosis is deficient enzyme. At this stage, at your level, only the name of the disease and the concerned enzyme defect or the particular biomolecules, like in this case, what mucosaccharide is actually accumulated. These 3 things will be required at this stage. But since this is a lysosomal storage disease and this will not be able to break down the mucopolysaccharide, so there will be deposition. So, many features will be common in these conditions. Only thing is that you have to have a suspicion and the actual confirmation will be done by the enzyme assay analysis or the concerned gene analysis. So, here you see this picture, the Hurler syndrome and Hunter syndrome, it will be very difficult to, diagnose the disease at a very early stage, particularly if the treatment is not initiated before 2 years of age, around 18 months to 30 months of age. Even after that time, if the treatment is done, the actual symptoms will not pass away. It will be alleviated only. The disease cannot be reversed. The treatment for this Hurler syndrome is basically hematopoietic stem cell transplantation. What you say, what you know, there is a bone marrow transplantation. Cost is very high, number 1. Number 2, getting a donor. Now, this disease is autosomal recessive in nature. Remember, this is an autosomal recessive disorder. That means both the parents were affected. So, among the siblings, it will be very difficult to get a donor. So, we have to get an allogenic donor, means somebody has to donate. Now, in that early period of 2 years, why I am telling all these things, they are not required at your class, but because of early clinical exposure, I am telling you. So, getting a proper donor for this patient will be a difficult one. And the bone marrow transplantation or the stem cell transplantation has to be done within 2 years' time. Otherwise, it will not be that much effective. Even after giving bone marrow transplantation, the problem will not end. You have to give a therapy with L-iduronidase almost throughout his life to reduce or alleviate some degree of symptoms. So, this is a real problematic case. Both the parents are affected, they did not know anything. Unfortunately, a baby was born. Second case, what I have shown it to you. This is what I have shown it to you. This picture, these are still photographs. The accumulated gag will be, in most cases, it will be darmatan sulfate or heparan sulfate. 3 diseases I am telling you, which are relatively common and where treatments are available, that is Hurler disease, Hunter disease and Slice syndrome. Slice syndrome I will show it to you. In all these three diseases, there are two mucopolysaccharides are in common, that is dermatol sulfate and heparin sulfate. See, this is a 10-year-old boy. Again, this is an X-linked recessive. X-linked recessive, mother is carrier. Now, imagine the condition of that family and imagine the condition of the mother. So, the deficiency, this is a type 2 mucopolysaccharides or MPS II. You just remember the deficient enzyme is iduronate sulfatase. The first enzyme was Hurler and the deficient enzyme is L-alpha-iduronidase. L, remember L for Hurler. And Hunter is, there are two iduronate, T is there, sulfatase T is there. So, Hunter you try to remember by iduronate sulfatase, and since this is Hurler is number 1, so there is only one term is there, L-alpha-iduronidase, and here it is 2 means you will get 2 at least words, that is iduronate sulfatase. So, with this I am telling you because it is very difficult to discuss all these things. These are real pictures from our own population. Here one important thing I would like to say, back to in the first case, there was a bone marrow transplantation or hematopoietic stem cell transplantation would be a proper treatment, but here it does not work so nicely. So, enzyme replacement, that is ER means enzyme replacement, ERT also there, enzyme replacement therapy. So, enzyme replacement is the only option and the cost is prohibitively high. I have checked it last night, the cost is around 40,000. So, 40,000 weekly injection. Now, you imagine the degree of cost. So, almost 40,000 into 4, say 1,50,000 or 1 lakh per month. Is it possible? So, that is the magnitude of the problem and you have to detect the disease early. So, this structure I have shown it to you already, 20 minutes are over. If I cannot complete, I will take one more class, but I am going a little slowly. So, collagen I have discussed in the early class. The first 6 slides I am just repeating for your own understanding. That is 29 types of collagen. This slide I have shown it to you. This is available in the book, nothing to say, only you have to remember there are 29 types of different types of collagen and they are present in different proportion in different tissues. So, more than 30 genes are involved and there is a very much complex process of synthesis, particularly post-translational modification, and because of these genes, 30 genes are involved. So, obviously there will be mutations and there will be disease and the manifestations will vary from disease to disease. Only thing is that you have to be aware of. So, defective gene will include defective enzymes. I have told these things, there are 5 common types, particularly the first 4 types, type 1 to type 4. It constitutes 95% of the collagen of the body. And I told you earlier also that collagen is the most abundant protein in the body and albumin is the major protein in plasma or serum. Don't get confused. So, you have to remember only type 1, remember always, I told you again earlier also, it is present in the bone, specifically type 2 in cartilage, type 4 is in basement membranes, MCQ is likely from type 4, which type of collagen is there in the basement membrane. So, you try to remember whatever you say, and reticular fibers is for type 3. The functions of the collagen in the first class I told you in brief about all the functions of the extracellular matrix, and there I have covered these things, but you still remember that collagen provides tensile strength and I have explained it earlier also with this structure. This is basically the structure of collagen. I will tell you very briefly about this thing. So, they basically support the tissue, and there will be huge amount of interaction, a large number of interaction with many things. Only I have mentioned five proteins, but there are a number of proteins, as you will see. Only a few I have written because of the time constraint, and at this level you are not supposed to understand, know all these things. So, since the collagen is the most abundant protein even in the vascular, in the vessels, if collagen, because of the damage, if collagen is exposed, that will form a nidus for clot formation. That is one thing. So, platelets will adhere and it will cause a thrombus formation. So, integrity of the intimal layer of the blood vessels are very much important, but because of the disease process, if that is damaged, then collagen in the extracellular space will be exposed and it will trigger platelet adherence and thrombus formation. So, structure of the collagen, I have told you, if you remember in my amino acid and protein class, this I have discussed, that this is a triple helical structure. This is a typically this particular 3 electrical cords I have expressed. This is the triple helix. There is 3 polypeptide chains and these are bound together. This is typical helical structure. This is typical what I have shown it here. This is the structure. So, there is only some important points like Glycine-X-Y repeats will be there, and that will constitute nearly 30%. So, glycine is there, X is usually proline, Y is usually hydroxyproline, but hydroxylysine will also be there. And since glycine is present at every 3 positions and glycine is the shortest amino acid, so it produces a very compact structure. If glycine is replaced by any amino acid, then the collagen formation will not be appropriate and there will be disease of the collagen, that you must remember. Now, when this structure is formed initially, there is a left-handed helix first, and then once that fibril is formed, then there will be right-handed helix, like this one. This will form first when it will be, this structure will form, it will form a left-handed helix. This will be left-handed helix initially, and there will be a right-handed helix finally, and there will be supercoiling. So, the structure will be very much compact and its tensile strength will be very much high. So, it will again this collagen fibril is formed, that fibril will be arranged in a quarter staggered arrangement. Remember, quarter staggered arrangement or quarter staggered alignment, what is that? Quarter staggered, remember this particular 3 or 4 things, one is triple helical structure, one is Glycine-X-Y repeats. Glycine is the simplest amino acid, the smallest amino acid, and presence of glycine at every 3rd position gives its a compact structure. So, once a collagen fibril is formed, this is arranged in a quarter staggered arrangement. Suppose this is one collagen fibril. This is another collagen fibril. This is another collagen fibril. Now, when the second one is placed, this will be placed after 1/4 distance, like from here. Okay? So, up to this much it will come. So, this again will come this much. Third one again will come this one. This will come here. This will go from here. 1/4 of the previous distance will be basically covered. So, this is almost 1/4. Now, I am telling you 1/4 more. Now, concentrate here only in this part, first part. So, you see between these two fibrils, there is a gap. there is a gap area, and these gap areas are filled up by other proteoglycans, glycosaminoglycans, or in the bone it will be formed by the calcium hydroxyapatite. And you see there is a gap zone, and there is overlapping zone also next to it. These two things are overlapped. So gap zone is alternating with overlapping zone. So this structure gives a very tight appearance. Now if there is if this gap is widened, then the collagen structure will not be that much compact, and this happens during old age. And if the connecting material, which is whatever is present like gags or proteoglycans, if it is, or protein molecules, if it is absent, then that tightening structure will not be there, and that again happens in the old stage. That's why the skin structure, whatever is present in the younger age or in the is not like that in the older age. So this area is, again, this is a collagen structure. Collagen is a very stable protein. It doesn't get destroyed, but collagenase enzyme can destroy it. And metalloprotein is another enzyme that also is reduced in the old age, I will say, during aging. So that also causes destruction of the collagen. So because of that thing, there is laxity, and when there is a wound, collagens will be destroyed. That destroyed, so some amount of collagens will be destroyed. So these collagens, which are produced mainly by the fibroblast in almost all tissue, and in bone tissue it is produced by the osteoblast also, are destroyed by the enzyme called collagenase. This collagenase is again produced by the fibroblast, even neutrophils, and they destroy the collagen extracellularly. So this I will tell you shortly. So this is what is called quarter staggered arrangement. There is a gap zone, there is a overlapping zone. You remember, from the book you will. So gap zone, overlapping zone, gap zone, overlapping zone, and this will give a very tight, compact structure, what I have shown it to you. Now at the end you will get a collagen fibril. This fibril will form a left-handed helix first, and then right-handed helix. Finally that will twist to form this type of triple helical structure. Okay. So this is what is quarter staggered arrangement. The proline and hydroxyproline, I told you earlier, it confers rigidity, and glycine at the third position gives a very compact structure. Proline and hydroxyproline gets, proline can get, hydroxylated to form a hydroxyproline. Lysine can get also hydroxylated by lysyl hydroxylase. So prolyl hydroxylase and lysyl hydroxylase, these are all vitamin K and copper dependent enzyme, vitamin C and copper dependent enzyme. So they are stabilized by the cross-link. Not only this thing, this happens, what happens? Once this structure is formed, a final collagen matrix, collagen fibril is formed. This is the collagen fibril. During the formation, there will be some extra amount of polypeptide at the amino terminal and some on the carboxy terminal. These will be post-translationally processed. This I will tell you, this is rod-like structure, what I have shown it to you. So this is now coming to the collagen synthesis like insulin. It is formed as a pro-protein. So P-pro-collagen is formed first. So there will be a signal peptide. The P-pro-collagen will be formed, and that signal peptide will direct the collagen to enter into the endoplasmic reticulum. In the endoplasmic reticulum, that signal peptide is clipped up. Now next it enters into the endoplasmic reticulum, and the leader sequence, that is the signal peptide, is removed, and the proline and hydroxyproline, proline and lysine, they are hydroxylated to form hydroxyproline and hydroxylysine. Lysine in addition gets glycated, so glycosylation of lysine is also there, and once this structure is formed, then the actual structure will be formed this one, and along with that there will be excess of amino terminal and carboxy terminal. Okay, so that structure is called porocollagen, while still the extension peptides on either sides are present, and that forms a triple helical structure while it is within the endoplasmic reticulum, and then it gets stored into the Golgi apparatus. In the Golgi apparatus, the porocollagen, this aminopeptidase and the carboxypeptidase, they are removed. So finally we get the structure of collagen, and that is called a tropocollagen. This tropocollagen, once it is formed, it undergoes self-assembly, or they interact with each other, and each polypeptide then at that stage will have an 1000 amino acid length, and these protocollagen, these fibrils again are stabilize this structure. These structures are stabilized by cross-link, the intrachain and interchain. Suppose here and here, in this chain, to this chain. So this structure will be further stabilized. So that stabilization is made by the Lysyl oxidase, that is called cross-links. So you can imagine if the Lysyl oxidase doesn't function, so that compact structure or the tensile strength of the collagen molecule will not be there. So Lysyl oxidase enzyme requires copper as a cofactor. If copper is again absent, like other coenzymes, if the cofactor or the coenzyme is not present in adequate amount, the enzyme will not function optimally. So that will happen. So this is a little bit about collagen. So collagen, as I told you, is a relatively stable protein. I mean, it is formed after so much of effort, so it will not be easily destroyed. Only thing is that when there is a prolonged fasting, that is called starvation, then only it is a structural protein, fibrous protein. It doesn't undergo destruction. So only in prolonged fasting, that is called starvation, this collagen can also undergo breakdown, like inflammatory diseases, like when there is an injury, that is a disease process. So when somebody is undergoing fasting, that is starvation condition, you see the severe muscle wasting, and the cause of this thing is that the structural proteins are destroyed. So these collagens are normally kept in as such, but matrix metalloproteinase enzyme, remember, note down one thing, matrix metalloproteinase enzyme, it cleaves or breaks the collagen, elastin and laminin. This is a non-specific enzyme. There are multiple metalloproteinases, and these metalloproteinases will be required. You will understand or read during your surgery class, or during the wound healing, or in the pathology class, how a wound heals. Because matrix metalloproteinase plays an important role. The damaged collagens are destroyed, damaged elastins are destroyed, and new collagen formations are formed. And when there is a deficiency of these matrix metalloproteinase enzyme, then this destruction will not be there. One set of matrix metalloproteinase is collagenase. Collagenase is a type of matrix metalloproteinase. Only it is a subset of metalloproteinase, and it cleaves the fibrillar cartilage of type 1, type 3 and type 3 only. Okay. So formation I have told you. So this is the structure what I have described. This collagen structure, amino acid sequence, collagen molecules, then packing of collagen, this quarter staggered arrangement, the gap junction, overlap junction. You can see the gap junction and overlap junctions are alternating with each other, and finally the compact structure is just like a bundle. You can see I have a video, I will not be able to show it to you because of the constraint of the time. Maybe in the SCT class I will show it to you. The entire structure, how it is formed from the fibroblast, how it is packed. It is a 4 minutes video, you will understand everything. So cross-linking, as I have expressed to you, that cross-linking between the collagen fibrils. So this is accomplished by the Lysyl oxidase and polyl hydroxylase. So post-translational modification is another important thing. There might be a short note also. Post-translational modification of collagen. Remember there are two parts, one is intracellular and one is extracellular. What is intracellular? The signal peptide cleavage will be done intracellularly. Then there will be hydroxylation of proline and hydroxylation. Then the glycosylation of these you have to remember, nothing much to understand. Only thing the points have to remember, the lysine and hydroxylation and formation of intra and interchain disulfide linkage. Actually, during this stage, what happens, it is having an carboxyl end and an amino terminal end. In the carboxyl terminal end, there will be intrachain disulfide bond. And on the carboxyl side, there will be interchain and intrachain both. So, twisting occurs from the carboxyl side towards the amino side at this stage. Now, then there will be triple helix structure will be formed. So, triple helix structure up to triple helix structure, it is within the cell, that is called intracellular, and extracellular, then once it is clear, it goes out of the cell, then only there will be cleavage of the amino acids, and the carboxyl terminal extra extension peptides, what I have shown it to you. Then the assembly of collagen fibrils, the quarter staggered arrangement, what I have shown it to you, this will be done in the extracellular space only. And then oxidative deamination by the Lysyl oxidase enzyme, and there will be cross-linking also intra and intrachain cross-links. This is written in the book, you need not write down. Only thing is that you just remember the post-translational modification of collagen can come as a short note. That's my point of telling it to you. Now, some collagens do not form fibrils. Like one is, fibril forming is only a number of collagens. There are 29 types of collagen. So, there will be network formation, reticular formation, there will be beaded filaments, there will be facets, that is fibril associated collagens with interrupted triple helix. That triple helical structure will be interrupted. So, that is facets, there will be multiplexin, a transmembrane collagen, that is one is integrane, I will show it to the picture. So, depending on the structural requirement, the collagens will exist in different forms. So, then coming to elastin, as I told you, it is present in the elastic tissue. There is a difference between the collagen and elastin. So, collagen is synthesized as a porocollagen, pre-porocollagen, then porocollagen, then tropocollagen, finally collagen. In contrast, elastin, pro-elastin to mature elastin, and then elastin is again broken down into elastase, just like collagenase, but elastin fragments are produced, but without any cross links. This is the difference, and there is a chart. What is the difference between the elastin and collagen? Whatever is present, structure is present, are conspicuously absent in elastin. See, collagen, we have said triple helix. There is no triple helix. Glycine-X-Y repeats. It's an unique feature. It is not present in elastin. So, as I told you, collagen gives a tensile strength. Elastin gives a elasticity property. So, hydroxylase again a catch question. Hydroxylase is present in collagen, but hydroxylase is not present in elastin. Carbohydrate containing glycosylation occurs in the hydroxylase, but there is no glycosylation. Presence of extension peptide is again, see in one short question, one MCQ, all of the followings are present in elastin except, or all of the followings are present in collagen except. Or what is the difference between collagen and elastin? Many different genetic types, as I have seen, the 29 different types are there, 30 genes are involved, but here it is only one genetic type, and important part is the intramolecular cross-link, but here it is intramolecular desmosine cross-link, and desmosine cross-link involves basically 4 lysine molecules. This structure you will see in your book. So, all these things which are present in the collagen are not present in the elastin. Characteristically, the aldol cross-links which are present in the collagen, here instead of aldol cross-linking, desmosine cross-linking will be there, and desmosine cross-linking involves 4 molecules of lysine. This is the structure of the desmosine structure. So, elastin will be present in the species which can stretch and recoil back, like heart, like blood vessels, like uterus. Lungs is a good example. So, these structures are conspicuously absent, I have told you. So, fibrillin is just 3 things you remember. Fibrillin is one component, it is a major structural protein of microfibrils, and it is a providing scaffold for attachment of other proteins, particularly in the ECM. And short question MCQ, defective fibrillin gene in fibrillin 1 causes Marfan syndrome. Marfan syndrome is caused by all options fibrillin 1. So, you remember this thing. So, fibronectin is an important part, I am telling you. Fibronectin basically corrects many important proteins. So, it binds, as you can see, there are 4 different binding sites. One binds with collagen, one binds with the cell, one binds with fibrin, another binds with heparin. So, this is a key player of between this fibronectin, between cell to cell communication, cell adhesion, and in cancer the level of fibronectin is decreased. That is why the cell adhesion is decreased, and there will be metastasis. I have told you in the first class also. So, the fibronectin role is cell adhesion, cell to cell interaction, and it also helps in cell migration and differentiation. Fibronectin plays an important role in wound healing, because during wound healing, again the structure has to be made back to its original form, and if the fibronectin is not formed, so the properties of the fibronectin, that it binds all the essential elements like collagen, fibrin, heparin, and also the cells, that is 4 different sites in fibronectin molecule. So, it connects all these things, all these 4 structures, and if fibronectin is not produced in adequate amount, then there will not be proper wound healing, or wound remodeling, you can say. So, fibronectin is, you can see the structure of the fibronectin. See, the fibronectin structure is present in the interstitial matrix. So, these are interacting with a number of proteins. Whatever I have said, it is not that a few numbers, but the numbers are many, particularly vinculin, spectrin, all many things are the polygon, many things are there. This interaction of fibronectin, I am telling you, this is integrin receptor. Integrin protein is a transmembrane protein, and fibronectin is having 3 polypeptide structure. This integrin basically. Now, you see it is interacting with the collagen, it is interacting, fibronectin is here, and laminin is also there. So, talin, vinculin, pexillicin, alpha-actinin, these are several proteins with which it interacts, and these are called attachment proteins. Remember, these are attached to the fibronectin receptor, anchoring the ECM. The main job of fibronectin is to attach the cellular cytoskeleton with the extracellular matrix cytoskeleton, so that the cell is bound to the extracellular matrix. So, anchoring the ECM, anchoring the cells with the ECM. So, there will be intracellular and extracellular communication through fibronectin. So, this is structure of the integrin. You see the integrin is a transmembrane protein, and this is a binding site for the extracellular ligands, this is the binding site for intracellular components. So, it basically communicates between the intracellular component and the extracellular compartment, and the structure is not so simple as schematically shown. It is again a schematic diagram showing multiple interactions, but in reality you will not see this structure under the microscope, even in the electron microscope. This is purely a schematic diagram for understanding only. So, this is the integrin receptor, it is having, you see, this is the structure, this is schematic diagram, it is a transmembrane protein, remember it is a transmembrane protein only, as a cellular receptor also. So, laminin, important component just like type 4 collagen, it forms the basal lamina, and it is having a network like structure with 3 polypeptides alpha, beta and gamma. You may not be able to remember all these things. In the cornea, this laminin is present, and those who will be specializing in ophthalmology, there will be requirement of determining which structure is damaged and what is the degree of damage. So, confocal microscopy, the corneal cells, the laminin part will appear as magenta and laminin will appear as a green, and corneal cells will appear as a magenta colored structure. So, importance of laminin. So far you have read during your protein class that albumin does not normally come out from the glomerular filtrate because of the lower molecular size, which is not the only cause and the actual cause. If you look at the basement membrane structure, it is basically 2 separate sheets of structure. One is endothelial cell, which is formed by the capillary, and another is epithelial cell formed in the basement membrane, that is the nephron. So, these are basically laminin is there. So, laminin is present in both the places, one in the capillary endothelium and also in the basement membrane of the Bowman's capsule. It allows small molecules like less than 5.2 kd, means 5200 molecular weight only. Pores in the glomerular size is 8 nanometer, remember this pore size, and the diameter of albumin is 3.8. So, diameter is less, so albumin can easily pass through. So, this is not allowed because albumin is normally negatively charged at physiological pH. Its pK value is nearly 4.7. So, albumin is negatively charged, and the basal lamina, there is a heparin sulfate and sialic acid component. These are also negatively charged. That negatively charged repel each other. So, albumin molecule cannot pass through basically because of the negative charge repulsion at the glomerular membrane, because of the structure of the ECM where the heparin sulfate and the sialic acid component also bear negatively charged. So, there will be repelling. So, you write down 2 mechanisms why albumins are not present. Commonly perceived mechanism is this thing. Fortunately, I inquired from a senior resident of medicine, and why albumin is not present in normal urine. At least instead of size, he emphasized this point. So, I am telling you at this stage because from this stage you must know about this thing, that whatever is taught, whatever in the first year class or the second class may not be true in the final year. And if you in your subsequent years, even we did not know this thing during our MD class when I have passed MD in 1990. So, long back this concept was not there. So, many new concepts are coming. So, you just remember the importance of laminin about the glomerular filtration. Now, keratin all you know, that is present in the hair, nail and hoop. These are very tough structure and it is formed by the alpha keratin and keratohyalin is present. You remember there is nothing more to remember about this keratin. How is laminin interact with each other. This is a very complex structure. Integrin, as I told you, this is a transmembrane protein. It is mostly present in the basolateral surface and the basal surface also. So it is present in the dimeric form. One catch question MCQ I have seen in GIM1 and AIMS question paper that there is what is the molecular glue? What is the molecular? They will write down all these things. What is the molecular glue? Molecular glue is integrin. Remember, and that attachment proteins. You remember what are the attachment proteins? Write down, make a short note that what are the attachment proteins and what is the molecular glue. Molecular glue is fibronectin, integrin, remember. So, again just like your active state, inactive state, you have seen that phosphorylation, dephosphorylation. Like here, the adapter molecule is serpin and tallinn. Now, integrin, when it is attached to serpin, it becomes inactive because of the conformational change, and when it is when the tallinn is attached to it, it becomes active integrin. It functions normally. So, apart from all these things, vinculin, tallinn, these are called again adapter protein. Adapter protein, attachment protein. These you write down. This might be a short note or short question MCQ. Because of the trend I am telling you, the question papers are really difficult, MCQ particularly. So, it connects cellular cytoskeleton to the extracellular matrix, just like almost fibronectin. So, ECM components are like this. So, laminin I have discussed, laminin I have told you, the complex interaction, the structure ground-like substance which you see under the microscope is not that simple. It is much more complex and is full of intramolecular complexes of multiple proteins, gags, proteoglycans, proteins, many things. So, bone is a mineralized structure. As you, I think bone has been covered in your, in your anatomy class or physiology class. Bone formation, bone structure was there. So, you are aware of it. So, Habertian system, canal, bonular, histopathology of bone, until and unless you will not understand this thing. This is I am telling you purely from a biochemistry side. So, it is principally found in the bone is a mineralized structure and 90% of the body's calcium are stored in the bone. I think these are not covered. What are the non-collagenous part of proteins in the bone? Bone connective tissue, collagen is abundantly present because it gives tensile strength. Apart from that, there is a plasma proteins, osteopontin, osteocalcin, osteonectin, and bone morphogenetic protein and bone sialoprotein. These are all present in the as a protein structure in the bone. So, osteoblast, osteoclast, and osteocyte and osteoid, I think you are all aware of it. You remember osteoblast and osteoclast, these are have an important role in formation. Osteoblast basically produces osteoid tissue which forms the bony matrix, the matrix of the bone, and it finally gets differentiated into osteocyte. So, osteocyte is formed from osteoblast. Osteoclast is another structure which is involved with the bone resorption. Osteoblast is involved in the bone formation. Osteoclast is involved in the bone resorption. Okay. So, remember osteoblast bone deposition, osteoclast bone resorption, at least you must be able to tell, and these when the osteoclast will operate. When bone calcium level is low, চলে এসছে আরে 5 মিনিট আছে স্যারকে বলা শুরু স্যার এই প্রভাস এসে 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 জাস্ট 2 মিনিট কভার করবো আসলে এই ঘড়িটার দিকে তাকাচ্ছি আমি কন্টিনিউয়াসলি So, basically what happens when there is a requirement of calcium, so the activity of the osteoclast will be enhanced by the effects of the hormone to release more calcium in the blood. So, osteoclasts, how osteoclast operates? By lowering the pH, that hydroxyapatite formation which is formed, from there the calcium is released. So, bone mineralization is there and all these structures are involved. One is osteoblast, it produces bone formation, alkaline phosphatase releases phosphate to form the calcium hydroxyapatite. Mineralization is first evident in the gaps between successive collagen molecules. These structures, I have told you the gap, this gap will be filled in the bone by this mineralization during bone formation. Bone cellular protein and osteoprotein, I have told you, non-collagenous protein, they act as sites for nucleation. Vitamin D is required for calcium absorption, PTH regulates calcium level, calcitonin inhibits bone reabsorption, and estrogen in females during the reproductive age of life, it plays an important role in calcium homeostasis because it inhibits all the process of, first and foremost, it inhibits bone remodeling, where bone structure is somewhat compromised, and the osteoclast activity is lowered, osteoblast activity is there, but after the menopause, this structure, this axis gets reversed, and that's why we need to give calcium to prevent osteoporosis as much as possible, along with vitamin D, so that the vitamin D is absorbed. Unfortunately, I did not know, despite being a doctor, because these were not told, and my mother sustained fractures in both the necks, and she was bedridden for 12 long years before she passed away. So, thereafter I made it a point to all my sisters, I have 5 sisters, that you take calcium to prevent at least osteoporosis as much as possible, because once fracture is there, particularly in the weight-bearing joint, usually life is compromised to a great extent, maybe wheelchair bound. That's what has happened. Anyway, so after menopause, this remember, so you try to give particularly those persons who are not aware of it. So with this I end, Professor has entered. I will discuss rest of the things later. Since we have not opened the books, you will not understand even if I tell many things. So I have told you several pictures from our OPDs, the diseases of the collagen, and today I have told you 2 rare diseases, Hurler syndrome